Okay. Hey guys, so we're going to talk about chapter 14, bleeding, shock, and soft tissue injuries. There is a lot on this chapter. Um, there's quite a bit towards the bleeding and soft tissue that works best with hands-on, but shock is a huge portion of EMR, EMT, advanced paramedic. Um, there's multiple types of shock, and we're kind of going to go over those. This is one of them things you need to read your chapters. Uh, a really good idea of what shock is and how it presents. So we'll get started here. As always, we're going to kind of skip through this stuff. So you need to learn how to use your assessment to find these life threats. So we know ABCs are life threats. So bleeding, um, recognizing and how to control it and what different types of bleeds there are. Head and facial, neck and spine trauma, recognizing those and how to treat those. Chest traumas, there's different types. Your blunt versus penetrating, open chest wounds, and impaled objects, and of course, how to treat them. Abdominal, um, anything in the abdomen area, pretty much. So, blunt versus penetrating. Uh, I can't say that damn word, but it's when your innards are laying out. So, if your intestines are outside the body, and then impaled objects, soft tissue. Um, Wounds, burns, electrical, chemical, and thermal are your types of burns. And then chemicals and the ion on the skin. How do we treat that? Multi-system traumas. This is when there's trauma to multiple body systems and how we recognize and treat those. Immunology, recognition and management of shock and difficulty breathing related to anaphylactic reactions. Disease of the eye, ear, nose, and throats. Nosebleeds. So, and damage to your internal soft tissues and organs can cause life-threatening conditions. So, we're going to look at internal bleeding results in shock. Uh, what shock is, it's the state of collapse of the cardiovascular system that results in inadequate delivery to the blood or organs. Blood to the organs, sorry. More trauma patients die from shock than from any other condition. And we're going to get into this, but shock can be broke down very simply to your heart, something's not working with it, your pipes or your vessels and veins and arteries, something's wrong with them, whether they dilate or constrict when they shouldn't, um, or the fluid, so your blood, um, or any body fluid that you might need. So, example there is severe diarrhea or vomiting times 5 days, severe dehydration. You don't have enough fluid for your heart to pump to keep your pipes full. You're in a form of shock. So your heart, your pipes, and your fluid, if one or all of them go bad, you're going to have some form of shock. So as always, we begin with our assessments. We want to do our scene size up, moving on to our primary, our history taking, our secondary, and then our reassessments. So we want to follow those steps. Your scene size up needs to ensure safety, both you, your partner, and your patient. Uh, you may need to halt primary assessment if the patient is losing too much blood. So this is where we change the ABCs and we go CAB. So if we're severely bleeding, that's considered circulation. So it's CAB. Stop the bleed, then worry about the airway and the breathing. Because if we're bleeding out, and we're not cycling oxygen like we're supposed to. So it doesn't matter if you're breathing correctly, right? So, um, anytime there's a major bleed, we take care of that first. During that secondary assessment, be alert for signs and symptoms of shock from internal or external blood loss. And as we go, we'll talk more about that. Follow the steps of patient assessment. Um, so when performing a reassessment, watch the patient for the following signs and symptoms of shock. So you're going to have pale skin, increased pulse rate, decreasing blood pressure. So what shock does is your body's this awesome machine. It will pull blood away from all your unnecessary things like your arms and your legs, and it pulls all the blood into the middle, into your core. And the way it does that is it constricts all your vessels and arteries and veins. So everything's tightened up around your extremities so that blood flow does not flow there as easily. It keeps the majority of the blood in the center of your body. So that's why we get those pale, cool hands and pale, cool arms, legs. Um, Even your face will turn pale because blood's not cycling to all of those little capillaries and stuff along the surface of the skin that makes us look nice and pink. So we have that pale, cool look. Um, Increased pulse rate is your heart is beating up, trying to feed your body. And then we get that decreased blood pressure because we're constricting on the outer extremities, we are dilating everything in the center core so we can pump more blood to what's important. So your blood pressure will skyrocket. Um, or sorry, decrease because everything is um, dilated. So we're going to get pale, cool, clammy. If you can remember them, you've got shock. They're going to look white. They're cold to the touch, and they'll almost feel sweaty or sticky. Some standard precautions for soft tissue injuries. Assume that all body fluids are potentially infectious. That's why we wear our gloves on every call, no matter what. Take appropriate measures to prevent contact with patient body fluids. Wear your gloves. If appropriate, wear a surgical mask and eye protection. Um, During the pandemic, we were worried about airborne or aerosolized infection threat. So coughing, sneezing, um, anything that came out of that body that might get into the air, we were wearing our N95s, our face mask, and all that. So now we're going to get into a little bit deeper stuff here. Already kind of went through and highlighted some of the stuff that's pretty important, but the circulatory system, it begins with our heart, um, our cardiac muscle, our veins, our lungs, our arteries, our capillary beds. Um, so pretty much it's a nonstop cycling system where blood is returning to the heart. Let me see if I can get my laser pointer here. So right here, this is our um, right atrium, our right ventricle. So it goes right into the heart, okay, right into the heart through the right atrium. It contracts into the right ventricle. From the right ventricle, it's going to go through your pulmonary arteries or arteries to your lungs. This is where that cellular respiration takes place in our alveoli. So oxygen goes in to the lungs. Um, Blood goes into the lungs where oxygen goes on board at the alveoli, carbon dioxide is off boarding. It then returns to the heart through the left atrium, pushes down to the left ventricle, and you can't see it because it's on the back side of the heart, but then it goes up through your aorta to the rest of your body where we feed our tissues. Um, and at the same time, we are onloading carbon monoxide and we are offloading fresh oxygen. So it's a constant cycle where oxygen is going to work, carbon dioxide is leaving work, if you look at it that way. Um, so just remember, blood goes right into the heart through the right atrium, right ventricle to the lungs, from the lungs, left atrium, left ventricle. It left the heart going to the body. You can remember that, you've got the heart down. So your pump, this is your heart, your cardiac muscle. The heart functions as a human circulatory system's pump. The heart consists of four chambers, which we talked about. There's two chambers on the uh, top of each side, left and right. So those are your atrias. And then your lowers are your ventricles. Let's see. So your right atrium, blood goes into your right ventricle, your pulmonary artery, which this one goes here. There's one that goes behind the heart over here. So this goes to your left lung, this goes to your right lung, and returns to your left atrium, down into your left ventricle. Once again, up that back side right here, behind your pulmonary artery, to your aorta, and shoved out to the rest of your body. So I'm gonna back up for a second. There's a really cool video on YouTube. It's like 3D blood flow of the heart or something like that. I will see if I can find it and maybe show it in class when I'm in there one day or something. It actually shows the actual flow because why your right atrium is filling, your left atrium is filling at the same time. When it gets pumped into your right ventricle, your left ventricle is getting filled over here at the same time. So it's actually coming in together, going down, going out, in, down, out, all at the same time. So it's not like four separate chambers. It's contraction, blood shoots out, it relaxes, blood fills in on both sides, it contracts, blood leaves on both sides. It's a really cool video and it will visually help you see what the heart's doing. Then we go to pipes. So arteries carry blood away from the heart. So let me, is it, that it? Sorry, trying to figure out. I was trying to find my highlight. There it is, highlighter. So artery starts with an A, away starts with an A. Okay. Arteries go away from the heart. Veins come back. Um, so capillaries form a network of distributes blood to all parts of the body. Veins return blood from the capillaries to the heart. Just remember that. A for artery is away from the heart. Veins return blood to the heart. Um, I don't want to go into that. So fluid, um, liquid part of the heart is plasma. Red blood cells carry oxygen and carbon dioxide. White blood cells consume bacteria and viruses to combat infection in the body. Platelets form clots that help stop bleeding. I don't want you to get too over carried away with this. There's only going to be a couple questions that are important that cover this. White blood cells consume bacteria and viruses. Okay, this is your army. These are your soldiers right here. Red blood cells carry oxygen and carbon dioxide. Platelets are what form clots. Okay, your pulse, a pulse is a pressure wave generated by pumping action of the heart. In a conscious patient, you can easily find a radial or wrist pulse at the base of the thumb. Patient appears to be in shock or is unconscious. Attempt to locate at the carotid. I cannot stress how important it is for you to actually practice this even on yourself. Just sit there and find your radial pulse, which is hard to do on camera, but feel around until you find your radial pulse. And then sit there and feel your carotid. Because when seconds count, and I promise if you join EMS, there are going to be times when seconds count. Being able to pinpoint a pulse is vital. So practice on yourself. I'm going to tell you, even go as far as doing like the PDO pulse down on the foot. It's on the top inner part of your foot. Just practice that on yourself. Shock is defined as a failure in the circulatory system. Circulatory failure has many possible causes, but three main causes. And we talked about this earlier: pump failure, pipe failure, or fluid loss. One or two or all three of these, something messes up, you're going to have shock. You can have shock based off psychological, psychogenic. Girlfriend broke up with her boyfriend, or boyfriend broke up with girlfriend, and she goes into a panic attack. That is a form of shock. If her body does not know how to handle it, her heart speeds up, it's not pumping like it should, she's not breathing like she should, she can go into shock. You can have septic shock caused by infection. I think there's 7 main forms of shock, and I'd have to get into my advanced book to look, but just remember, make shock easy. Your pump, your pipes, or your fluid. Cardiogenic shock occurs if the heart cannot pump enough blood to supply the needs of the body. Pump failure is a result from a heart attack. Inadequate pumping of the heart can cause blood to back up into the vessels or lungs, resulting in congestive heart failure, CHF. I'm not going to go that deep. If you move on to EMT, we will go deeper into what CHF is. Pipe failure is caused by the expansion of capillaries to as much as 3 or 4 times their normal size. Blood pools in the capillaries. The rest of the body is deprived of blood. Blood pressure falls and shock results. So everything opens up. You don't have enough fluid to fill the pipe, so it just kind of sets in there. The example I give to my night class is if I took a 4-inch fire hose and I hooked it onto my water hydrant at my house. Am I going to be able to fill that fire hose and spray water? No. And that's essentially what's happening with your capillaries. Anytime that we dilate like that, we are using the same amount of force. So just like our garden hose at the house, it's made the size it is for a reason. If I hook a 4-inch fire hose to my water hydrant at home, I've taken all the pressure from behind that. It's just going to run through. It's not actually going to have force behind it. And that's what's happening at the capillaries and these veins and arteries whenever they dilate out, is we lose all of our blood pressure. Shock introduced by fainting is psychogenic shock. Fainting is the body response of a major psychological or emotional stress. As the nervous system reacts, capillaries suddenly expand dramatically. Fainting is a short-term condition that corrects itself once that patient is placed in a horizontal position. So we get the heck scared out of us, and we get super stressed and we faint or pass out. As soon as we hit the ground and we're flat, our body naturally will go back to normal size. We restore blood flow and we wake up and we're fine. Um, and your entire body goes all at once, all your blood pressure drops, nothing's being fed on that oxygenated blood, and so we pass out. Anaphylactic shock, this is caused by an extreme allergic reaction to a foreign substance. Patient appears flush, breathing may become difficult, and blood pressure drops rapidly. Death will result if prompt action is not taken. So, anaphylactic shock, um, I think everybody thinks of a bee sting or something like that, a peanut allergy. Um, we are introduced to an allergen, our body doesn't know how to react. Um, this is where we use those EpiPens, this is where we use breathing treatments. I don't want to go into EMT stuff, which I was fixing to. Septic shock, leaky or porous blood vessels dilate due to overwhelming infection throughout the body, life-threatening emergency, which often occurs in older adults. Septic shock is going to come with high fever, weakness, very, very sick people. And you can have young ones. I've seen like 23-year-olds who have septic shock. So it doesn't have to be older people. Spinal shock, also referred to as shock, may occur in patients who have sustained a spinal injury. Injury allows capillaries to expand and the blood pools between level of injury. Brain, heart, lung, and other vital organs are deprived of blood, resulting in shock. There is another word for that, also referred to as, I can't think of it right now. I will do some reading though and get back to you. Fluid loss caused by excessive bleeding or hemorrhaging is the most common cause of shock. So blood escapes from a wound, the system's total fluid volume drops, heart begins to pump faster to maintain pressures in the pipe. The pump eventually stops pumping, resulting in cardiac arrest. This is why we stop bleeds as soon as they start. Fluid loss, so external bleeding is not difficult to detect. Obviously, red stuff's pouring out, we make it stop. With internal bleeding, bleeding cannot be seen, but you may see these signs. So bruising, swelling, rigidity in the affected area, severe pain in the immediate area. Whether bleeding is external or internal, it will remain unchecked. If it remains unchecked, it will be shock, pump failure, and death. So if we're bleeding out, we can see that. We can fix that. These are going to happen in a lot of your blunt force traumas, your car wrecks. In our area, it might be getting hit by a bull at the rodeo, getting kicked by a horse. Trying to think here, a significant fall. Um, and so, what we do during our assessment trauma, so we go trauma naked, we look for discolorization, so that bruising, swelling, obviously, rigidity. So when we push on the abdomen in all four quadrants, If one is harder than the others, or the bottom half is hard and rigid, that's a good indication. Severe pain in that immediate area, yeah. So the other thing that I teach students is anytime there's possible pelvic fracture or broken hips, we really need to pay attention to make sure we're not internally bleeding there too, because that pelvic girdle, if you remember, it's shaped kind of like a bowl and it can hold a huge amount of blood inside it if you have internal bleeding without us ever knowing it. So that's why it's super important to continually do assessments, watch for those trending injuries or those trending vitals caused by injuries. Um, there's just really no good way to go about that besides you constantly be reassessing, looking for these things. An average adult has about 12 pints, that's 6 liters of blood circulating in the system. Loss of 2 or more pints, that's 1 liter, can lead to shock. Shock deprives the body of sufficient blood to function normal. As shock progresses, the body alters its functions in an attempt to maintain sufficient blood supply. Signs and symptoms of shock is confusion, agitation, restlessness, and anxiety. Cold, clammy, sweaty, pale skin. Um, your main ones, like I said before, cool, pale, cool, and clammy. Those are just the telltale giveaways that's easy to see really quick. Signs and symptoms of shock: rapid shallow breathing, rapid weak pulse, increased capillary refill time, um, nausea and vomiting, weakness or fainting, thirst. Position patient correctly. So if the patient has no head injuries, extreme discomfort, or difficulty breathing, lie the patient flat on his or her back on a horizontal surface. Consider elevating legs if your protocol says that's a shock treatment. You can raise those legs 8 to 12 inches, and it helps keep that blood towards the center of the body. Maintain patient's ABCs, treat cause of shock if possible, maintain the patient's body temperature. Do not allow the patient to eat or drink. Eating or drinking may cause vomiting. Patients in shock may need surgery and should not have anything in their stomachs. So let me see where this goes. Assisted patient treatment. If you are trained to administer oxygen, provide it to shock patients. Advanced emergency medical technicians or paramedics can administer IV fluids. Arrange for transport. So with shock patients, pale, cool, clammy, we immediately, shock is a life threat, so we immediately lay them down, um, place a blanket on them because we want to maintain body heat. We need to keep them warm. And then not just place oxygen on them, we're going to put a non-rebreather at 15 liters per minute on them. I don't care if their pulse ox or their SpO2 says they're at 98. If they are showing signs of shock, we flood them with oxygen. Um, and this shock is a life threat, so it's going to be a rapid transport. We're not staying and playing, we're going to load and go. So anytime in real life or in scenarios throughout school, you hear pale, cool, clammy, you treat for shock, lay them down, cover them up, give them high flow oxygen, and we rapid transport. Treatment for shock caused by pump failure. Um, I'm going to tell you it's the same. Uh, we treat for shock just like I just explained it, and we rapid transport. Treatment for anaphylactic shock. So transport as soon as possible. Some patients may carry an epinephrine auto injector. Assist the patient with your local protocols. Allow uh, you've been trained to do so. Support the patient's thigh, and place the tip of the auto injector against the thigh. Push the auto injector firmly into the thigh and hold it in place for several seconds. I was taught 7 to 10 seconds. So we slam into the thigh, we hold 7 to 10 seconds, and then we're going to rub in a circular motion the injection site, and that diffuses that medication out to the tissue. We do have practice epis at school that we can practice with. With anaphylactic shock, the main thing we want to do is maintain an open airway because a lot of times it will swell shut. The tongue could be swelling. So we've got to keep that airway open. Early detection and early interventions goes a long ways with anaphylactic. Treat for neurogenic or spinal shock. Keep spine in a neutral position, support the patient's ABCs, treat symptoms of shock, arrange for prompt transport to appropriate facility. This is anytime we have a spinal injury. You're going to get the same type of signs and symptoms, pale, cool, clammy. These are the people that we're going to put on a full body vacuum splint or on a spine board. Just kind of reading through here. So treatment for septic shock, support ABCs, treat symptoms for shock, arrange for prompt transport to an appropriate medical facility. So don't make this too hard. Signs of shock, we treat it and we rapid transport. You do kind of need to have an idea. Neurogenic is spinal, septic is going to be infection or bacterial. Hemorrhagic is going to be fluid loss. You kind of need to have an idea what each type of shock is, but don't beat yourself up trying to memorize like every sign and symptom because it's pale, cool, clammy. That's what you need to know. Shock caused by internal blood loss, bleeding from the stomach ulcer, ruptured blood vessels, or tumors can cause internal bleeding and shock. Patients with internal bleeding may exhibit, they may exhibit coughing or vomiting up blood, abdominal tenderness, rigidity, bruising or distension, rectal bleeding, vaginal bleeding in women, or classic signs of shock. Doesn't matter. We're going to do our assessments just like we always do. And we're going to treat as we find them. So if we find shock, we treat for shock. Rigidity, bruising, or distension. So rigidity, we talked about, we're palpating the abdomen and it's hard. Okay, that's rigidity. Bruising is that discolorization where everything's just a little bit darker, maybe purple or blackish. And then that distension is if you can actually sit there and watch their stomach puffing up and you're not giving oxygen or anything, they're filling up. We got to watch that. So controlling external bleeding. So these I think are kind of common sense, but that's your everyday paper cut. You get a little bit of blood. That's a capillary. It's small amount of blood. Your venous is down here on B where it runs out. It's a steady flow. That's a vein. Direct pressure will usually stop that. And then your arterial, this is where it's going to be squirting. These are going to be really hard to do. You direct pressure, and then when that doesn't work, we do a tourniquet. So capillary bleeding, most common type of blood loss. So blood oozes out. Apply direct pressure to the site. Venous bleeding. This is the second most common type. This bleeding has a steady flow. Apply direct pressure for 5 minutes. If it still doesn't stop, you can use a tourniquet. Most of the time with a vein, good hard direct pressure, you'll get it to stop. Then you've got your arterial bleeding. This is the most serious type of bleeding. Arterial blood spurts or surges with each heartbeat. Um, exert direct pressure and maintain pressure until EMS arrives. It may be necessary to elevate or even use a tourniquet to control that bleeding. So direct pressures, we place a dry sterile dressing directly on the wound and press with a gloved hand, wrap dressing and wound snugly around with a roller gauze bandage or an ACE bandage. Uh, do not remove the dressing after you apply it. So every human who has ever been fascinated with EMS has done this at some point. So we hold that direct pressure for a minute or two, and instead of being intelligent enough to go, I'm just going to leave that there. We all do the same thing. We all lift it up and look under to see if it's still bleeding. All that we're doing is we're pulling that scab away, or that those platelets that have formed that clot. We're pulling that clot away and starting over at square one. Once you apply direct pressure, you do not ever remove that gauze. If it bleeds through, you add another gauze on top of it, and you add another on top of it, and you add another on top of it. This says 5 minutes. Um, to me, 5 minutes is a long time to sit there and let someone bleed. If I'm dealing with a pretty good bleed, I'll use an abdominal pad. They're a lot bigger and thicker. And if we bleed through two of those, I put a tourniquet on. Elevation, if direct pressure does not stop external bleeding from an extremity, elevate the injured arm or leg and maintain that direct pressure. It just slows the pressure of the bleed down a little bit. It makes the heart work a little bit harder to pump uphill, is all it does. And then tourniquets, we can practice these in class. Um, there's a lot of misunderstanding on tourniquets. It used to be like, oh, you can't have a tourniquet on for more than 2 hours or you lose your arm. That's not true. It went from like 2 hours to 6 hours to 12 hours, and I think it's up to like 16 hours now. You can actually have a tourniquet on and not lose that extremity. Um, so what we do with tourniquets is, if see if I can do this without my camera messing up. So if I'm sliced down here, I'm still going to put that tourniquet clear up here. You don't want to go over the shoulder bone, but you want to go directly under it. It's called high and tight or high or die, whichever one you remember. So we put tourniquets from here down, okay? And then when we do lower extremities, there's no way around this. We're getting really friendly. We go as high as we can without getting on our reproductive organs. And that's for men and women. Like, you're a tourniquet and a man, you might have to push some stuff aside and make sure that tourniquet's all the way up in there. Uh, it's just, we're saving lives. We're not, there's no way around that. It's high and tight. Um, so we place that tourniquet on, we cinch it tight. I'm a big advocate on educating your patient. So we're going to tell them, hey, you're not going to like this. This is going to hurt like hell. I have to do this to get this bleeding to stop, or you could die. And we're going to start twisting, and they're going to start screaming and yelling and cussing. And you're going to twist until you can't twist anymore. And then we're going to lock it into place. That tourniquet has that little white tag. We're going to pull that tag over and we're going to write the time on it. If you forget the time or the tag, I don't know why they made them white. If that tag's covered in blood, we can write on their forehead. We can write on their arm. Just jot down that time that tourniquet went on. Once that tourniquet's on, go ahead and check for a pulse. If you have a pulse, that tourniquet's not tight enough. You should not have a pulse after a tourniquet application. With that being said, on the lower or on your lower extremities, on your legs are a lot bigger around and beefier. So there are times when we might actually have to apply two tourniquets to the same leg. Um, what we want to do is we want tourniquet number one to be here, and we want tourniquet number two to be as close as we can to it without touching. We don't want a gap in between here. We want it right up here close. If we've got a gap, we can create what's called compartment syndrome, and that's where we get a stagnant blood between the two. And stagnant blood becomes toxic blood. And so in 6 hours, when a surgeon takes that tourniquet off, now we have toxic blood. So we get those tourniquets as close as we can. I usually say a half inch is plenty. And sometimes it takes two tourniquets to stop a severe leg bleed. Hemostatic dressings. So these are those dressings. They're also known as combat dressings. They have a hemostatic material in them that actually increases the clotting ability of the platelets. So it actually speeds up the clotting process. Um, let's see. Some diseases such as hepatitis and HIV can be spread by contact with blood from an infected person. Wear your gloves um, all the time. By the time you get out of the ambulance, you should be putting your gloves on. Um, or if you're responding in your private vehicle, keep gloves on you. Um, if you do get blood on your hands, wash it as soon as possible with soap and water. If you cannot wash your hands, use a waterless hand cleaning solution um, that contains an effective germ killing agent. A wound, wounds. A wound is an injury caused by any physical means that leads to damage of a body part. Wounds are classified as opened or closed. That's exactly what it sounds like, also. So a closed wound is the skin remains intact. Only closed wound is bruise. Injury or soft tissue beneath the skin, small blood vessels are broken, area becomes discolored or swollen. A simple bruise heals quickly. Bruising and swelling may be a sign of an underlying fracture. So know your calls, do your history, get an idea of what happened. If we feel it's even a possible fracture, we're going to go ahead and splint. An open wound results in the break of the skin. Abrasions, also called a scrape, road rash, or rub burns, occurs when skin is rubbed across the rough surface. Puncture occurs when a sharp object penetrates the skin, may cause deep injuries that is not immediately recognized. Puncture wounds do not bleed freely. An impaled object sticking out of the skin. A gunshot wound is a special type of puncture wound. So here we have a nail through the finger. That is a puncture wound. We have a piece of wood shoved in. That's like a splinter. That's what's happening on the inside. Laceration is the most common type of open wound, commonly called a cut. Minor lacerations may require little care. Large lacerations cause extensive bleeding and can even be life-threatening. So that looks like a pretty good laceration. Avulsions and amputations. An avulsion is a tearing away of the body tissue. The entire body part is tore away. Oh, an entire body part is tore away would be called traumatic amputation. So I'm going to back up avulsions. This is where a flap of skin is tore loose, but it's still attached. So we've all had these type of injuries where you kind of want to pull that piece of skin off. That's not what we're supposed to do. You're supposed to lay that flap back over and bandage it. Um, so an avulsion is a flap of skin. It doesn't tear all the way off. Amputation, parts should be located, placed in a clean plastic bag, kept cool, not frozen, taken to a hospital for a possible reattachment. That's a pretty good one. That's an avulsion. So if you look at B there, you see how it just flopped over. That's that avulsion. Believe it or not, it's taken me like 6 years to learn how to say that word. Um, Very minor bruises. So principles of wound treatment, very minor bruises need no treatment. Other closed wounds should be treated by applying ice and gentle compression and evaluate injured part. Splint all major contusions because they could be fractured. Stop bleeding as quickly as possible using the cleanest dressings available. Dressing a bandage Dressing and bandaging wounds. So dressing and bandaging are applied to control bleeding, prevent further contamination, uh, immobilize the injured area, or prevent movement of an impaled object. Dressings is an object placed directly on a wound, control bleeding, and prevent further contamination. Once a dressing's in place, apply firm, direct manual pressure on it to stop any bleeding. Three most common sizes are 4x4s, 5x9s. Those are like the abdominal pads I was talking about, and 10x30 trauma dressings. Dressings, if bleeding continues after you have applied a compression dressing, put additional gauze pads over the original dressing. Don't remove them, don't take them off, don't look underneath, just keep adding to them. Bandaging, it's used to hold dressings in place. Roller gauze and triangle bandages are commonly used in the field. So roller gauze, I think we all kind of know this right here is your roller gauze, and this right here is your triangle bandage. We use triangle bandages actually to build sling and swath. So the shoulder wrap for like dislocated arms, we use that for that. We can use them to, if we're building a homemade splint, we can actually tie the splinting material to the broken arm or leg or whatever, and use them as to secure things. They're pretty handy. Ensure the dressing is completely covered, covers the wound and extends beyond all sides of the wound. Wrap bandage just tightly enough to control bleeding, but not so tight that circulation's cut off. Check circulation regularly. So we're always going to check our pulse before, during, and after treatment. Secure bandaging so that it cannot slip. Let's see. Standard precaution techniques. Wear your gloves. It's Wear your gloves. Face and scalp wounds. So a relatively small laceration to the face or scalp can result in large amounts of bleeding. You can control almost all facial and scalp bleeding by applying direct manual pressure. Direct pressure compression compresses blood vessels against the skull to stop bleeding. So, with this being said, we apply moderate pressure. That's just my favorite word when it comes to head wounds. We do not do direct pressure to the face or head, because if I have an injury that's significant enough to split my skull, my skin up here, or the back of my head, or wherever, it may have had enough significant pressure to actually fracture something underneath. So the last thing I want to do is have someone crushing down on broken bone, pointing it, pushing it into my brain. Same with my face. You don't want to be pushing things in. So face and scalp, we do moderate direct pressure. I'm not telling you just lay it on them and leave. I'm saying put it on there and hold it, but I'm not putting my body weight on them trying to stop a bleed. So what they did there, they're holding that nice moderate pressure. They get it kind of under control, and then they use an ace or a bandage or a wrap, to hold it in place. They're not wrapping him so tight his eyes are popping out, though. For wounds inside the cheek, hold a gauze pad inside the mouth. Always keep the airway open. Um, I'm going to make my patient hold that gauze in their mouth. They are not biting me. If they're awake and they're alert, they can hold that gauze. Don't get any bright ideas. Don't pour like blood stop in their mouth and think that's going to stop the bleed. We're not playing that game. Uh, Scalp lacerations can be associated with skull fractures and brain injuries. If a brain tissue or bone fragment is visible, do not apply direct pressure. Cover wound loosely. With head injuries, neck and spine may also be injured. Move the head as little as possible and stabilize that neck. Motion or monitor the patient's airway and breathing to protect the spine. So you're going to learn how to read your scene, read your call, look at your mechanism of injury or your nature of illness, and kind of get an idea what might be going on. Um, Anytime that you have trauma, damn near any trauma, especially in school when you're doing scenarios, you are going to do C-spine. Just get used to it. If you walk into a trauma scenario or you're doing trauma scenarios, just know that you are going to do C-spine. It's right there on a sheet, BSI, scene safe mechanism of injury. How many patients do I have? Call for additional resources. Um, is this my only patient? And I'm going to consider C-spine. It's right there in the top. So just get used to that. Nosebleeds can result from injuries, high blood pressure, or dry air. A nosebleed is no apparent cause, with no apparent cause is called a spontaneous nosebleed. Management, unless the patient's experiencing shock, have the patient sit down, tilt their head slightly forward, and pinch their nose. Something else you can do that I'm pretty sure it doesn't talk about in here. Lay an ice pack on the back of their neck. It will constrict the vessels. That cold will cause everything to constrict, and it will slow the blood going to the facial area, and it will slow that nosebleed down. When the eye injury, sorry, when an eye laceration is suspected, cover the entire eye with a dry gauze pad. Have the patient lie on his or her back and arrange for transport. If a small foreign object is laying on the surface of the eye, use saline solution to flush the object from the eye. If we have an impaled object, immediately place a patient on his or her back and cover the injured eye with a dressing and a paper cup so the impaled object cannot move. Bandage both eyes, arrange for transport. So what they've done is they've taken a cup and put it around the object, and it allowed them something to secure to. So the gauze right here is secured to the cup, not to the pencil. Well, at the same time, I want you to look over here as I put an X on her. What happens if I hurt this eye, but this one's still good? I'm still gonna like try to look around, right? Well, when I look around, this one moves. So the idea here is we take away vision in both eyes so that she or he does not start trying to look around. Because when one eye moves, so does the other one. And that's the last thing we want in this situation. So we secured this object all the way around. That object is not moving, and we are going to transport very gently. We don't want any sudden movements. Wound necks. This is a little bit different monster. Use direct pressure to control the bleeding. Once bleeding is controlled, dress the neck. So it depends on where that wound is. This has always kind of screwed me up as well. Yeah, we can do some direct pressure if we need to. Um, if it's a main artery, though, I don't know if direct pressure is going to do it. And then it looks like they took some Coban or Tegaderm down here. They just wrapped it or covered it. So Tegaderm, for those of you who don't know, is that little clear stuff that we use over IVs. Like we stick the IV and then we put that clear saran wrap over it. That's what that is right there. Neck wounds are just different. Just stop the bleed the best you can. Don't put a tourniquet on them. In rare cases, you may have to insert a finger uh, pressure above and below. Exert finger pressure above and below the injury site to prevent further neck bleeding. Major trauma to the neck may be associated with airway problems and with neck fractures or spinal cord injuries. Maintain that patient's airway, stabilize the head and neck. So above and below, if that cuts right there, um, we've got so much arteries and stuff that veins, and you're just gonna have to play that one the best you can. Chest and back wounds. So place patient with a chest injury in a comfortable position. If a lung is punctured, air can escape and the lung will collapse. Patient may cough up bright red blood. Cover the chest wound with an airtight material, occlusive dressing, and administer oxygen. So chest injuries are going, hopefully these are blunt force trauma, and we're not looking at a penetrating trauma. Um, but you can get both. So if there is an open wound, we want to cover it, um, monitor their SpO2. That's going to be a huge one. Um, as those lungs collapse or that lung collapses, we're going to lose some of our SpO2. So you're looking at probably 85 to 91 will be their saturation on a healthy adult. Call a medic, call a helicopter. These are prompt transports. Chest wounds may damage the heart. So seal wounds and monitor ABCs, which we talked about. Treat patients for shock and perform CPR if necessary. Yeah, their pulse goes away, do CPR. If a patient's breathing becomes more labored after you seal wound, remove the seal briefly and allow excess air to escape and then reseal. So you seal that wound up and in 30, 45 seconds, they go, I can't take a breath. Pull that seal off, and it's going to release all the pressure that has built up because there's so much air inside the lung cavity outside of the lung that it's putting pressure on the lung. So if we release that air, that lung can go ahead and expand. Um, it would be like me holding a balloon and telling you to blow it up. If there's pressure, you can't get air into that balloon. But if I release that pressure, now you can blow that balloon up, right? So that's the same thing here. We've got all this air compressing around the lung that it can't move. I release that air, that pressure, and now my lung over here can actually expand. Impaled objects. So we're going to treat these just like we did that impaled injury. We don't remove them. We You don't have to put a cup over it, but we're going to secure it in place. Um, and that might mean that you put, and I've seen this done. I was actually on the call with the paramedic who did it. We took two roller gauze and there was a knife in the chest, and we put those roller gauze on each side. And that's how we secured that knife. We started wrapping the whole chest, and we would use them roller gauze as a guide. So we weren't wrapping around the knife, we were wrapping up against it. Um, so we secure the object in place the best we can, and we transport extremely gently. Um, that right there, that's a perfect example. So ice pick, what they did here is they put a towel on either side of that, and then they wrapped all the way around it. So that's exactly how you do that. Closed abdominal wounds result in direct blows from a blunt object. Look for the bruising or other marks to the abdomen. This is where we're talking about that rigidity, that tenderness, that discolorization. Um, Pay attention to shock. We are going to take vitals constantly on this person. Place these patients on their backs and elevate their legs if your protocol allows it. If you suspect some kind of spinal injury, don't do that. Use a blanket to conserve their body heat. So, how do we treat for shock? We're going to lay them down, we're going to cover them up, and we're going to flood them with oxygen, right? If a patient's vomiting blood, it may be an indication of bleeding from the esophagus or stomach. Monitor that airway and vital signs. Give the patient nothing by mouth. Arrange for prompt transport. Especially if I've got a traumatic injury of some kind and they're throwing up blood, I'm calling a helicopter. That's my personal opinion. But right there, monitor the airway and vital signs. We cannot take enough vitals with these patients. We want them talking to us. We want that CAPNO on them. We want SpO2 on them. We are taking a blood pressure every minute to every 2 minutes. And what we're looking for is we're making sure that that very first blood pressure of, let's say, 120 over 80, we do not want to see 110 over 60, 100 over 61. We don't want to see that slow trend because that means we're losing blood. So we monitor these people fast and often. Open abdominal wounds. This is going to be the one where I couldn't pronounce the word earlier. Usually results from a slashing with a knife or other sharp object. If and the intestines are protruding, place the patient on his or her back with knees bent. Cover the injured area with sterile dressings. Do not attempt to replace intestines in the abdomen. Don't push things back in. Once they're out, leave them out. We just want to cover that up with like a moist dressing. Even if that means we grab a bag of normal saline and we pour it all over one of our sheets and we lay that over them. That's what we want to do. Yeah. So on here, I mean, I know you guys got to do what your book says. Yeah, he's covering it up with the nice dressing. He's covering. I would not do D personally. Use several wide to loosely cover the trauma pad. Place just tight on it. Yeah, see, I'm not going to be reaching under him and tying something on him, but that's just me. Genitalia wounds, male and female genitalia have a rich blood supply, so injury to these areas can result in severe bleeding. Apply direct pressure with a dry, sterile dressing. Um, although it may be embarrassing to examine a patient's genitals area, you must do so if you suspect an injury. Guys, I'm telling you, I've done stuff that I'm not wanting to brag about, but these calls do happen. So you just got to remember this is a job. Personal. It's not, we're not out there to have fun. We're out there to help people. Um, I want to go back. And this one is for everyone, but especially with women, we do not insert anything into the vaginal canal. I don't care how much blood's coming out of it. You do not insert anything in. We take our abdominal pad, we will press it up against there, and we will just hold direct pressure that way. I shouldn't have to say that, but that's how I was taught, so that's how I teach it. Yeah. Extremity wounds, so apply dry, sterile compression dressing bandages. It's securely in place. Elevate injured part to decrease the bleeding and swelling. Splint all injured extremities prior to transport because there may be an underlying fracture. And if we don't splint a fracture and we take off down the highway and we hit a bump or a bridge, it can actually go ahead and break. And I have seen it happen. It's agonizing for the patient. Gunshot wounds, most deaths from gunshot wounds result from internal blood loss. Gunshot wounds to the trunk and neck can be a cause of spinal cord, can cause spinal cord injuries. Treatment, open airway and establish adequate ventilation and circulation. So we're make sure our ABCs are covered. Gunshot wounds, control any external bleeding with dressings and direct pressure. Examine patient thoroughly to locate all entrance and exit wounds. Treat the symptoms of shock. Arrange for prompt transport. Perform CPR if the patient's heart stops. So in these situations, this is a very high adrenaline, scary situation, no matter how good you are. This is where, and I don't know if I've talked to you guys about it or not, but you step back and you go, I know how to do this. Um, and you go down your steps. If there's an entrance wound, we look for an exit wound because you can put something over the entrance wound, but if you don't put something over the exit wound, it defeats the purpose. Um, you have to stop bleeding before we can do CPR because if we're doing CPR and they're just squirting blood out, it doesn't matter. Um, yeah, we treat for shock. We can flood them with oxygen. Um, and once again, on this one, prompt transport. This is a helicopter every time. Bites, they come with a high risk of infection. Patients should always seek treatment for a bite. Minor bites can be washed with soap and water. Major bites, control the bleeding and apply dressings. If there's a bite, though, make sure that scene's safe before you approach. Burns, skin serves as a barrier to prevent foreign substances from entering the body. It also prevents loss of body fluids. So when the skin is damaged, it can no longer perform these essential functions. So we have to watch for that infection. So I'm old enough. I grew up on first degree, second degree, third degree burn. Now it is superficial, which is first degree. It's going to be red and painful, and it affects that outermost layer of the skin. And pain, you're going to have minor to moderate pain. This is a sunburn. Partial thickness burn. This is second degree. Do not damage the deepest layers of the skin. It's going to blister, fluid loss, moderate to severe pain, uh, and will usually heal 2 to 3 weeks. This can be touching a stove. This can be touching the barbecue grill for a second. Severe sunburn that actually gets bad enough that it blisters. Then you have full thickness burn. This is your third degree. Um, Damages all layer of the skin. Pain is absent because it actually gets into the nerve endings and destroys them, so they don't feel anything. Patient loses large quantities of body fluids uh, and is susceptible to shock and infection. Uh, the extent of the burn, so rule of nine, which I hope there's a picture on here. There we go. So rule of nine, you don't necessarily have to know this perfectly, but you need to have a good idea of it. And I'm going to advertise here for a minute for Amazon. This right here. That's my rule of nine. I know it's kind of hard to see on my camera, but it's not working real well. So my rule of nine, I've got these cards that cover vital signs, 12 leads, everything. Um, I got for like 14 bucks on Amazon. There's 16 cards there or something like that. Because things like this is hard to remember. So we take an infant, the front and the back is 18. So 18 in the front, 18 in the back. The arms, this is 9%, this is 9%. The head is 18%. Genitalia is 1%. Each leg, 13.5. So we move over to like the toddler or child. The head is 12, torso 18, 18. Legs 16.5, 16.5. Arms are 9 and 9. We move over to the adult. 9% the head, 9 and 9 on the arms, 18 and 18 in front and back. 1 for genitalia, 18 for legs. This is percentage, so I don't like it. But what they do is if you get a burn victim and his entire right arm is burned, I can call the hospital and go, I have a like 18% burn, 9% burn. Um, yeah, I think it's 9. So I don't like the rules of 9. So the types of burn is thermal burn caused by heat, place burned area in clean, cooled water. Cover it with a dry, sterile dressing or a burn sheet. Do not break the blisters. A patient with large burns must be treated for shock and transported to the hospital. Respiratory burns, these are really scary. A burn to any part of the airway. Look for the following signs and symptoms: burns around the face, singed nose hairs, soot in the mouth or nose, difficulty breathing, pain while breathing, loss of consciousness as a result of fire. These patients, you better have someone ready for an intubation, because they can swell up and their airway can close in a matter of seconds. Breathing problems can develop rapidly or slowly, and extra oxygen and be prepared to perform CPR, arrange for prompt transport. And then we go on to chemical burns. Many strong substances can cause chemical burns. Longer chemicals remain on the skin or in contact with skin, the more dangerous it is. So treatment, we want to remove as much chemical as possible. Brush away any dry chemical. Flush with water for at least 10 minutes. Cover area with dry, sterile dressing. Arrange for prompt transport. So just remember, if it's a dry chemical, we want to brush it off as much as we can before we apply water, because what happens when we apply water to a powder? We create a paste. And the last thing we want to do is create a paste on someone's skin. Chemical burns to the eyes cause extreme pain and severe injury. So flush eyes with water for at least 20 minutes. Hold the eyes open and allow water to flow over the entire surface. Loosely cover injured eyes with gauze, bandages, and arrange for prompt transport. Electrical burn. I told you there was a lot on this chapter. This occurs when the electrical current enters the body at one point, travels through the body, tissues, and organs, and exits at another point of ground contact. Electricity causes major internal damage. Patients may experience irregularities of cardiac arrhythmia and cardiac arrest, and death can occur. Electrical burns. So be certain that the patient is not still in contact with that electrical power source before you touch or treat him or her. Call for assistance from the power company for a qualified rescue squad. Monitor ABCs of electric burn patients and arrange for prompt transport. Multi-system traumas. So multi-system trauma, like we talked about, affects more than one body system at a time. You are not expected to diagnose patients' injuries. Several body systems may be injured in situations that involve significant trauma. So be alert for signs and symptoms of injuries. Before we go any further, don't get tunnel vision. This happens to the best of us. My God, we had a car wreck and their face is bleeding and they've got a broken arm. Don't get tunnel vision. We do our assessment. Is a bleeding face and a broken arm, is that life-threatening? No. We continue our assessment. We do our ABCs. We go down the body, because what we didn't recognize is the broken femur that they're bleeding out because of. So multi-system traumas, we've got to be dedicated to staying on track. We follow our assessment sheet, we follow the steps, and we treat life threats first. So I'm not going to go through the summary. This thing has taken forever. There's a ton to learn about shock. We're not doing the test. reach out to me, please. If you have questions on this, you guys know I'll come up to the school and help you guys if you need it. Uh, Other than that, I guess I'll see you later.